Good way, Dr. Geldrix.
Thank you, Becky. Thank you so much, everybody, for joining today. Again, yes, very happy to be here and happy to speak to you about rheumatoid arthritis, or RA for short. I'll refer to that during the lecture. This will be a basic overview, including clinical signs, symptoms, and treatment approach. And happy to also take answers at the questions at the very end. So the objectives of the lecture we're going to review include the background, risk factors in disease pathogenesis, symptoms and early detection, treatment options, prevention, and the role of nutrition, and provide you with some resources at the very end as well. So I have here a schematic approach, a simplified way of looking at arthritis, because commonly we do see that the term arthritis is really thrown around and confused among different forms of arthritis, which, is expected. But this is a way to kind of think about it and to simplify how we look at it. We have in one area towards the left hand side is osteoarthritis, or in other words, degenerative arthritis from wear and tear arthritis. There is mild inflammation there, but it's not the type of inflammatory arthritis that we'd be speaking about during this lecture, which is what we see in the middle section of the chart here. Inflammatory arthritis is really an umbrella term which encompasses multiple types of arthritis, including rheumatoid arthritis, but we also have psoriatic arthritis and crystalline induced arthritis, or in other words, gout or pseudo gout, if you've heard. And then on the far right, there's septic arthritis, or this is more bacterial or infectious type of arthritis, which, today we are going to be focusing on rheumatoid arthritis. And again, it's to differentiate from the other types of arthritis and keeping that very clear when we're discussing here. Another point here in terminology when it comes to arthritis commonly gets confused is the words arthralgia and arthritis. So it's very important here that we distinguish this because, again, it gets a little confusing and nuanced. So the word arthralgia and arthritis comes from the root word, the Greek word arthron, which means joint. Algia means pain and itis means inflammation. So arthralgia on one hand side is more the subjective feeling that patients come in and with the complaint of joint pain. Arthritis, though, on the other hand, is more of a clinician and a diagnosis made by a clinician based on evidence, the objective evidence of warmth, redness, swelling, inflammation. This could be all around the joints, including tendons or ligaments, all involved. So all in all, you can have arthritis and arthralgia, but you don't necessarily need arthritis to have arthralgia. So this really does require the physical examination by a clinician to make this distinction between the two. In this case here, this is just somebody holding their elbow, having joint pain, arthralgia. Arthritis, on the other hand, this is really objective evidence on examination where you can obviously see there is redness, swelling, probably fluid there, and tenderness. If you were to blot the area around the knee, you can compare the two knees side by side. And this is the point, these are the evidence that point towards arthritis, where there's inflammation acting there. In this case, it's gout. And then we also want to keep in mind that there are periarticular anatomy structures that can be involved in inflammation, like tendons, ligaments, that are all around these joints. In this case, very commonly decurvain tenosynovitis, which is inflammation of the tendon. Again, very, very juxtaposing the joint space. So rheumatoid arthritis, RA, is a systemic autoimmune disease that is characterized by chronic inflammatory arthritis and extra-articular involvement. It affects the peripheral small joints symmetrically, very important, and if it is untreated, can lead to bony erosions, joint destruction, and deformities. RA can affect nearly every organ. It is very important to remember that is a systemic inflammatory disease. So it really can involve lungs, the skin, the eyes, bone marrow. That's all your bloodlines. your liver, your nervous system, and your blood vessels, as we will see. So this is just to bring your attention to basic anatomy of the joint. And you can see that there are multiple structures that are around and encase the joint area. You can see here that is the blue area that's nicely lining the two juxtaposing bones here. And that is the cartilage. Over time, of course, if there is damage, you see the erosions of that cartilage and the space. I do want to highlight, though, that the synovial membrane here in pink, that little lining, is what we are going to be really honing in on when it comes to rheumatoid arthritis. It's a very active component that becomes inflamed when we're talking about rheumatoid arthritis. Here it is. So the pathogenesis, in brief, this is the normal looking joint all the way on the left. And as you can see, the synovial membrane, again, highlighted in pink, very nice in a normal joint where there is no, they're really not supposed to be inflammatory particles and mediators that are in the space. You see very nice joint space. They're not abutting each other, and there's a nice capsule lining. The cartilage is all pointed out. As we enter early stages of rheumatoid arthritis, we do see the hyperproliferation of the synovium. You see the redness there that used to be nicely lined is starting to infiltrate up into the actual bony structures and into the cartilage, where you see now inflammatory cells begin to want to combat that infiltration. And so we have our own immune system that is now trying to combat this. That's why we see those cells in that joint space. Over time, this becomes more and more prominent, and you see the synovium further expand, and neutrophils, those are white blood cells, all of those start to participate in the inflammatory response, and you create this panish structure where there's a tugging and pulling onto the bony areas and causing erosions eventually in later stages of rheumatoid arthritis. So just a little more background here, the incidence and why this is important. So the incidence rate of rheumatoid arthritis is between 0.5 and 1% in the United States. We can really compare this to the rest of the world where 0.9% on it, roughly in India, or much less in the Middle East and North Africa. So something to think about when we think about how the Western world, compares to other areas in the world like the Middle East or in Africa, and there is a difference there. The onset is roughly between the fourth and fifth decades, and the incidence seems to increase with increasing age. Females tend to get it more frequently than men in a 2 to 3 to 1 ratio. Rheumatoid arthritis does increase with positive family histories. Lifespan is reduced anywhere between 3 and 12 years, again, highlighting why it is important to bring this to our awareness. And the risk of disability depends on the severity of disease onset. And here, the risk of heart disease does double. So these are just some pointers here. Risk factors. So when we do think about autoimmune and inflammatory diseases, we really have to think about a predisposed host. What does that mean? That means our own genetics plus environmental factors can really bring about disease, right? So there is an interplay between our genetics and the environmental triggers, as we're going to see, and I'll have a diagram for you. So what we do know, tobacco definitely is one of actually it is the most common risk factor that does trigger genes to become activated. These are like epigenetics, which means turning on genes and activating this immune response. Other known risk factors here, I've listed silica, asbestos, textile, dust, P. gingivalis, poor dentition, obesity, alcohol, and coffee, interestingly enough. What do we find? You may know, there's these autoantibodies. This is the autoimmune response. So we do find and detect these antibodies, rheumatoid factor or RF, and anti-citrullinated proteins or CCP or ACPA for short in the blood in a very good percentage, roughly around 80% of patients will have these antibodies. This is a nice diagram, again, simplifying how our genetic factors all the way on the left become triggered, with this unique interplay of our health, whether it's our a dentition, smoking, pollution, etc., can turn on these genes, leading to inflammatory disease, in this case, RA. So I like to say, because this does come up frequently, a common question comes up, which is, a family member does have rheumatoid arthritis. What are the chances of getting it? And the basic truth is that there is an increased risk, right? We do take account for them, but majority of people actually never develop rheumatoid arthritis just because a primary family member has it. So basically, what I like to say is that genetics load the gun and environment pulls the trigger. That's a very good way to sum that up. So the development and the disease course in rheumatoid arthritis, again, this is a very nice way to really think of how the phase of developing the disease, and there's still so much to be learned here, but we've come a long way with rheumatoid arthritis. So in phase one, on the left-hand side, again, are predisposed genes, and here it's laid out. There's HLA, multiple genes, the DR4, DR1. These are HLA genes, and those genetics, with the correct stimulus from the environment, pushes the expression of those genetics into this preclinical autoimmunity phase two, which is these antibodies and inflammatory cells become productive, active, and circulating in the system. Eventually, the duration between phase 2 and 3 is still obscure, very obscure, until eventually there is clinical signs and presentation of that disease very evident on exam. So in totality, 40% of patients who do have the RF and the CCP antibodies in that preclinical stage will highly likely move into the phase 3 stage. And really, it's the CCP antibody, because that is a specific antibody in rheumatoid arthritis that we're interested in, and 40% chance of then developing true RA on examination. So if there's a variety, very extreme variable presentation and patterns of presentation based on severity or progression among patients, but in general, this is a nice schematic way of how to think of the disease. So clinical presentation, there are 3 types I've listed here, but we are going to really hone in on the classic type of rheumatoid arthritis, which is the vast majority of rheumatoid arthritis. The other nuances with the other 2 versions of how it can present are even difficult for clinicians to really pinpoint. So even very senior rheumatologists, it's a very difficult, because again, they're very rare. So classic type of rheumatoid arthritis is what we are going to focus on. The other 2, palindromic rheumatoid arthritis and monoarticular rheumatoid arthritis. Again, both on the rarer spectrum. Signs and symptoms. So symmetrically involving multiple small joints, typically in the hands, wrists, but small joints. Chronic, meaning that symptoms have been lasting for 6 or more weeks. There tends to be morning stiffness, like around an hour or more, which may or may not improve with activity or throughout the day. There's pain, warmth, redness, and swelling around the joints, fever, fatigue, or malaise, unintentional weight loss, rheumatoid nodules, loss of joint mobility, function, and involvement of other organs. Like, for example, if the lung becomes involved, there might be shortness of breath, as an example. So really a wide spectrum of symptoms. And here is just an image of the progression of disease, where on the left-hand side in early rheumatoid arthritis, you do see areas around the joints in the middle knuckle here and the middle finger. There is obvious swelling. If you pay attention closely, you see the swelling in localized areas. And as the disease progression, you see multiple small joints involved, deformities, there becomes laxity around the joint space, again, because of all that tugging and inflammation going on, and it causes joint destruction, which brings you into later stage disease, especially if left untreated. You do see these knobs, these rheumatoid nodules. You see subluxation, again, because functionality is now being infringed on. And you see just complete loss of function in the joints. This is in comparison, again, bringing back how we discussed initially osteoarthritis. And I just put this here. It's a nice cartoon, but it really brings to the point of how we look at arthritis and which joints are they really being affected. This is important because of those symptoms. So we said rheumatoid arthritis symmetrically involves the joints, right? Versus osteoarthritis is more asymmetric. You get one knee, as you can see on the left-hand side in the blue, you get one knee, you get one hip, you get definitely in the spine, degenerative arthritis, as opposed to in rheumatoid arthritis, you get, the elbows. Those are not weight-bearing joints. You get the wrists, again, not weight-bearing joints. These are joints that are now being affected because of an inflammatory response that is not necessarily due to overuse, like in osteoarthritis. So this is a very nice picture that really depicts the distribution of disease in the joints. And that's why it is very helpful when it comes to symptoms. The extra-articular manifestations, as we said, this is a systemic inflammatory disease. So you get more than just joint inflammation. You can have inflammation in the skin, like a vasculitis, where the blood vessels become inflamed, as you can see in the left upper hand corner, along with the rheumatoid nodules. We do find those in later stage disease, untreated disease. We can find these manifestations. Below, you can see Sjogren's syndrome, which is another autoimmune disease, or dryness, episcleritis, scleritis, all inflammation in parts of the eye, all the way to you get ulceration, something very uniquely found, peripheral ulcerative keratitis. As you can see in the cornea, there's an ulcer there. And it needs very aggressive therapy, essentially. And on the right-hand side, we see inflammatory changes called interstitial lung disease on CT scan of the lungs. And you see this honeycombing, again, shortness of breath, a dry cough. These are all findings of poorly controlled disease, or sometimes, we do find these findings even in patients, again, because every patient is unique, even in patients who do have controlled disease, but usually they tend to tie together. Other extra-articular manifestations, we can't forget about cardiovascular. So these are all the coronary artery disease, like strokes, peripheral vascular disease, are all doubled in patients with rheumatoid arthritis, and is a major mortality risk. As we mentioned, vasculitis, you can even get effects of the disease in the kidneys, glomerulonephritis. Hematologic, there's leukemia that is associated with it as well, and neurologic manifestations as well. So the detection and the diagnosis, you should be recommended or referred to a rheumatologist to make this diagnosis. So what that means is putting the picture together, and that's our job. We take the clinical presentation, we put it in terms of what the blood tests show, and we make an inference on the diagnosis. So those serologies, like I mentioned, plus inflammatory markers, the CRP and ESR, that's the SED rate and the C-reactive protein. As I've said, around 80% of patients with rheumatoid arthritis will test positive for the rheumatoid factor and CCP, or both. And patients with these antibodies is essentially where we get the terminology seropositivity for rheumatoid arthritis. Those without those antibodies, we refer to them as seronegative. And there is that small portion of patients who do remain negative. So the treatment and management. The aim for treatment and management is to achieve disease remission. That is reducing the amount of joint pain, swelling, and really have a happy patient. being able to do their daily activities and with ease and comfort. We also want to reduce medication side effects with the goal of limiting the disease progression and reducing pain, preserving mobility, function, and improving overall quality of life. How do we do that? There's medications and different classes of medications, which I'm going to go into the next slide here. I've just listed them out. There's NSAIDs, non-steroidal anti-inflammatories, DMARDs, these are disease-modifying anti-rheumatic agents, and immunosuppressants or biologic, and steroids. And we use that in conjunction with our lifestyle and therapy options, right? We eliminate the environmental triggers. So if it is tobacco, we want to stop smoking, stop the alcohol. We encourage a healthy diet and exercise. And if we need rehabilitation and physical therapy is always a plus. As I mentioned, these are the medications that we commonly use and do have to use. Now, everybody is a little bit different, where there is milder disease presentation or versus severe disease presentation. And how we go about using these medications will be tailored specifically to each patient uniquely. So there's analgesics, like I mentioned, the NSAIDs, that's like your ibuprofen. These are over-the-counter pain medications. They do provide pain relief, but they don't slow down the progression of the inflammatory response. So we need to use disease-modifying agents. These are very commonly methotrexate or sulfasalazine, leflunomide. Which one we use all depends on risk stratification, risk and benefit with the patient, each patient specifically. And then we have the biologics, where if there is still evidence of disease and there is still swelling, manifestations extra-articularly, we have to add on therapy or potentially switch therapy. And we have many now on the market, as you've probably seen, like Humira. There's T-cell stimulators, there's infusions, JAK inhibitors were in vogue. These are all a lot of the commercial advertisement you probably are seeing in regards to treatment options here, which are important to bring up and have discussions about. So in this next segment, which I get a lot of my questions, is what can you do if you have or somebody you love with rheumatoid arthritis? What is your role? Because most of the time I hear from my patients that they want to take accountability here and they want to see if they can do something to help slow down the disease, stop the disease, prevent it. And all those questions that tie in with what can you eat, what can you drink, what can you do on a daily basis that can really strategize and personalize your health. So the next segment we're going to discuss is what can you do in rheumatoid arthritis in relation to it. So here we go. So the role of nutrition, what do we know? We do know that their obesity, elevated BMI, and especially the increased weight circumference. This is the weight that is specifically around your waist that actually infers that you have much more visceral fat, which means visceral inwards, right, around the organs. You can think of fatty tissue as a very live endocrine organ, that it really has chemical properties that is absolutely engaged with your overall health. There's hormonal imbalances that are going on. And we do know that obesity, especially, like I said, visceral obesity, plays a role here. And especially in the setting of metabolic syndrome, essentially that means elevated blood pressure, elevated cholesterol, and increased insulin resistance leading to diabetes. These are the three components in metabolic syndrome associated with development of rheumatoid arthritis, or even in rheumatoid arthritis that makes it a barrier to treatment. So this, of all the information I have tried to find and condense for you in a nice format here, there's a lot of information out there that's been tried to study, but the difficulty with the information out there about all of these supplements and environmental factors are very difficult to ascertain in the studies. Why? Because the version of the study, whether it was prospective, observational, retrospective studies, there's a lot of nuances that come and make it very difficult to actually put to test. And that is why it's been so hard for us to actually find and recommend certain things that are like very, very hopeful for patients. It's because the quality of the evidence isn't there. It is very difficult to extract and to actually put it to the test. But in any case, I did my best to try to present to you here in a condensed and concise way what we can offer, at least what we know to date. So in the purple column, you can see the risk of developing RA versus in the orange column on the right, you see the role of the nutrient there in established rheumatoid arthritis patients. We're going to look at the first row, harmful effects. So this we absolutely know in terms of the risk of developing rheumatoid arthritis, we do know that smoking and a high salt intake and sugary drinks especially, and plus or minus coffee, we'll talk about, again, very nuanced, but those have harmful effects in the development of RA. So these are areas where you can prevent, right? If you don't smoke, you can potentially take away that risk factor of developing rheumatoid arthritis. Going just down beneath that, protective effects. We do know that omega-3 fatty acids, those are very anti-inflammatory, provide anti-inflammatory benefits. These are found in fatty fishes, healthy sources like in the Mediterranean diet, very supporting that antioxidant effects, which in turn are protective in developing RA. What's been controversial, there have been some studies that show positive or negative, and again, this is empty basket here, red meat, primarily due to the high nitrite content, iron, vitamin D supplements, alcohol, and green tea. So those are a little bit hand wavy when it comes to making a direct correlation. On the right-hand side, in patients with rheumatoid arthritis, what do we know? Harmful effects. We do know that the gut microbiome plays a tremendous role in the entire health of our bodies, and especially our immune system. We almost have to look at it as a complete organ of itself that really has an interesting chemical makeup and communication way with the rest of our body. So the gut microbiome, in this case, there are certain unhealthy gut bacteria that actually have an interplay with the development of these citrulline proteins, these antibodies that end up leading to rheumatoid arthritis. Like I said, the periodontitis, these are all the bacteria that live in our mouth, for example. Those get swallowed down, but in other ways as well, other bacteria have been associated. Low vitamin D also, we do know, has a harmful effect in established rheumatoid arthritis patients. That's in patients with rheumatoid arthritis. Unfortunately, the evidence is not there for preventing rheumatoid arthritis. So in other words, taking vitamin D, if you do not have rheumatoid arthritis, is not going to protect you against developing it. Protective effects. If you are low in vitamin D, then we want to supplement the vitamin D. Caloric restriction and a gluten-free diet and fasting. These also do have some protective effects. Let's talk about caloric restriction and fasting. This, in consequence, may reduce your overall body weight, your visceral fat. And also transiently, there have been some evidence with intermittent fasting that do at least transiently reduce overall body inflammation. So it puts your body into a almost suppressed response. Just by not eating, you are actually suppressing the immune response. But of course, this may reduce your medication load. This may reduce how much, NSAIDs you take for pain, and so on and so forth. The gluten-free diet, on the other hand, there are hundreds of protein in wheat, and again, very dicey when it comes to trying to make conclusions on what exactly in the wheat that might be pro-inflammatory. However, we do know that having a healthy gut lining does protect against some of those proteins being leaked through, in a sense, through the gut, into our bloodstream and causing this inflammatory response. So that is why also fiber has been encouraged as well when it comes to having a healthy gut lining, to keep that lining as very healthy, and as much as possible not allow the leaky proteins to go through. Controversial, on the other hand, alcohol, probiotics, and antioxidants. Again, these role in established rheumatoid patients. Again, the evidence is just not fully there because of the difficulty with carrying out these studies. So I overall do encourage the Mediterranean diet. This is the healthiest diet that we can try to follow, again, to reduce overall cardiovascular risk, diabetes, cancer risk, neurodegenerative disease. And it does encompass a lot of what we've already mentioned here, where we are eating those healthy fats from fatty fishes, reduced overall red meat intake, lower salt diets, etc. Red wine does, of course, need to be looked at a little differently through a different lens because of the high antioxidant properties that are in it due to the polyphenol content. So not all alcohol is looked at the same way. So in summary, the Mediterranean diet is the most encouraged diet. Highly recommend 1 to 2 times a week to have a high consumption of fatty fishes like salmon, sardines, sea bass. Red meat should be limited to 1 to 2 times a month. Daily extra virgin olive oil is very, very important. Weekly consumption of other types of fish and poultry. High consumption of whole grains, legumes. 5 or more servings of fruit and vegetables daily, and even better if seasonal or locally grown. Sugary, sweetened drinks, salt, coffee, alcohol should be avoided or in moderation. And of course, physical activity. Vitamin D supplementation, as we mentioned, in established rheumatoid arthritis patients. This is a nice diagram that goes over holistically what we just mentioned here. On the left-hand side for healthy joints, right-hand side in red points out all the other areas that are of concern, potential triggers, again, with the right predisposed genetics that can lead to the development of rheumatoid arthritis. This is the Mediterranean diet, yep. And some educational resources to leave you with. So the American College of Rheumatology, there are great resources on here, from videos, PDFs, handouts, medications, many things to be accessed. Here are some other ones, but all very, very similar. You can find a lot of information here. So European Alliance Association of Rheumatology, National Rheumatoid Arthritis Society, Arthritis Foundation, a lot of great tutorials on there. Johns Hopkins Rheumatoid Arthritis video series, National Jewish Health, really great PDFs as well. And these are my references. And this is some of my contact information if you would like to reach out. There is our phone number, and we are, again, located in Ridgewood and in Montvale. We have 2 clinics now, and I'm happy to take any questions at this point. Thank you so much for your time.